So I'd like to say welcome to everybody to join this meeting from the Panamerican Society, University of Miami. This is the 11th year that you do these meetings, and you have been having multiple cases, multiple institutions being presented here. And today is an honor to have Dr. Major Paul Weinstein presenting. Paul is a great friend. He was a fellow here in Miami with us, and now he's part of the Army Trauma Training Department here in Miami. And it's a privilege to have him working with us daily here. And he's going to present a nice case that he had at our South Trauma Center Jackson South. I'm going to have great discussions, and I'm going to learn a lot to this case. So Paul, thank you very much for accepting the invitation to present this case. And this video, the video of this section, are going to be available at the Panamerican Society website afterwards for the ones that cannot see right now, or for used for review for teaching afterwards. Thank you, Paul. Welcome.
All right. Well, thank you, Dr. Martos, and good morning, everyone. And thanks for letting me present this case. It's one of my first cases that I got at our level 2 trauma center, Jackson South, as Dr. Martos has said. So the patient presentation that we received from EMS was that they were bringing in an 87-year-old male who had fallen from what we were told was 6 feet from a ladder onto a marble floor. They had unknown if he had lost consciousness in the field, but they were reporting to us that he was confused, perseverating on a headache that he had, and right shoulder pain. So he arrived to us where he was speaking with a patent airway. His breath sounds were equal bilateral. He had a regular heart rate, and he was, of note, he was hypertensive with a systolic blood pressure in the 180s when he came in. He had good pulses. His GCS was a 14, -1 for some confusion, and his pupils were equal and reactive. On his exam, he had a posterior scalp laceration, a right ear abrasion, and a hematoma, some pain with movement on his right shoulder, a skin tear on his elbow and his right wrist, and some impressive left ankle bruising. His FAST exam was negative, and he denied to us taking any antiplatelets or any anticoagulants on arrival. His initial chest x-ray, I hope that it comes up nicely on everyone else's monitor. If you cannot see, a few things that I'll point out that are obvious, if you can't see, is he has a both proximal and distal clavicular fracture. He also has obvious rib fractures on the right side from ribs 2. You can see him all the way down to about 9 on his chest x-ray. Otherwise, his lung fields are completely clear. His pelvic x-ray showed no acute findings. On his initial labs, we did, the only thing immediately available to us in resus was that his base excess was +2 and his hematocrit was 52. Later on in the CAT scanner, we found out his INR is 1.3, and on his tag, his R time was elevated and his MA was low. On his initial CT scan, you can see he has a right 2 by 2 centimeter intraparenchymal hemorrhage on the, as well as a subarachnoid on his left frontal. And then on the far right image here, you can see he has multiple skull fractures and with some depressed component posteriorly there as well. On the CT scan of his chest, our radiologist called a trace right pneumothorax. I was scrutinizing the images even after the case. I could not find the pneumothorax. They did read this small, what I'll circle with my mouse here, a small right pleural effusion, they called it, near those posterior rib fractures, and a fracture of his right proximal and distal clavicle, and a scapular fracture. So we returned to the observation bay. Neurosurgery was immediately consulted and was in the trauma bay with us. We gave him platelets to correct some of his abnormalities in his TEG. While he was in resus, he remained persistently hypertensive into the systolic blood pressure of 180s to 200s range. And after talking with neurosurgery, we elected to place a left subclavian central line in order to start him on a cardine drip. The left side was placed after one unsuccessful attempt at a right subclavian. It was unsuccessful, just we were unable to advance the guide wire on the right side. However, before we started him on the cardine drip, he decompensated rather quickly. His systolic blood pressure dropped to the 80s. He became lethargic, and this was about 2 hours after his arrival to the trauma bay. So at this time, I'd like to open it up for discussion about the differential diagnosis for his decompensation and whatever next immediate and secondary steps in management for this patient.
Thank you, sir. We have a lot of participants today, and which is a great thing. But with that said, let's do our best to just move it along as smoothly as we can and start with Boston. Dr. Oyman.
Okay, I doubt very much that the patient is hypotensive from the head injury. I would think he's probably bleeding in the chest. A blood pressure of 80 with a head injury is really a very bad combination. So I will quickly get the chest X-ray to see if there's any expansion of this. It looks like it's an extrapleural hematoma. Might have rupture inside the pleural cavity. And I would probably discuss with neurosurgery that maybe they would need to get the repeat head CT, but the first thing is to find where this patient is bleeding from.
Thank you, Dr. Oyman. University of Texas, Rio, Dr. Skubik. Long time no see. Good to see you, sir. Your comments, please.
Hi, thanks for having me back. I believe you said one of the last things that you did before this was attempted placement of a right subclavian.
Yes, sir.
Past the wire. I don't know, that stands out to me for some reason. You know, he had bad clavicle on the right, rib fractures there. He couldn't pass the wire. All of a sudden he's decompensating afterwards. I would worry that he has some kind of great vessel injury, maybe a right subclavian injury. I agree with Dr. Homan. You need to do something to assess what's going on in the chest again if you hadn't before, or you could repeat again an ultrasound, take a look at the pericardium as well as the right chest and see if it's filling up with fluid, or does he now have a pneumothorax there that's expanding? You need to reassess. When things go wrong, reassess, step back, maybe refast him and see if you can figure out what's going on with him.
Thank you, Dr. Skubik. Dr. Altman.
I agree with the previous comments, and we have to think about the pneumothorax as well, because it was described in the first CT scan, and it could be one of the reasons for the deteriorating of his clinical conditions.
Thank you very much, sir. Portland, Dr. Kassi.
I agree with Dr. Holman's assessment, but I would like to point out that this man has multiple fractures. He's 87 years old, and in older people, when they have multiple fractures like this, you could lose substantial amount of blood which doesn't show up, and then suddenly decompensate. But I think I am more inclined to believe my friend from Texas, that this thing happened after the initiation of the subclavian line, and then you had to abandon that. I'm wondering whether something went wrong during that procedure. whether he developed a pneumothorax, which became a tension pneumothorax, or whether he actually had some bleeding episode from that. So those are the things that is coming to my mind. When you do intervention and something goes wrong, you need to go back and check it out that you did not cause that problem. So that's what my thoughts are at this moment. Thank you.
Thank you very much, Dr. Kasim. Philadelphia, Dr. Alex.
Hello. Can you hear me?
Yes, sir. Loud and clear.
I agree with all the comments. And luckily, this patient was scanned, head down. And as the other participant said, you have to suspect something going on with regards to you have to consider that what you did the last thing maybe negatively affected the patient. And I think even putting a chest tube on the right side, given the fact they had a small pneumo maybe on the CT scan, you had a bunch of refractures, and you attempted a subclavian, may not be a bad idea just to go ahead even, put a chest tube on the right side to bring the blood pressure up, and then kind of, redo everything, A, B, C, D, E, and just look for other causes. But that'll be one of my first things.
Thank you, Dr. Alex. Lima, Peru, Dr. Calderon, your comments, please.
Yes, good morning or good afternoon. Yes, I was thinking maybe this patient was already bleeding somewhere. Maybe the abdomen, maybe it has more bleeding from the chest. And we also have in mind that he had a failed procedure, a failed line placement that may cause or a vascular injury or a tension pneumothorax. So what can we do with this gentleman who suddenly might be crashing? We have to repeat all the A, B, C, D, E. We have to repeat the chest X-ray to see if we have a pneumothorax or a bleeding or a hemothorax. Repeat the FAST to see some fluid in the abdomen or how does the pericardium look like. And if the patient becomes more stable, repeat the CT scans, especially in the chest and in the abdomen. Well, that's it. Thanks.
Thank you, sir. And United Kingdom, Dr. Villaquirin, your comments, please. Check your mic, sir. You're muted, doctor.
Sorry about that.
Okay.
I agree with all of the previous, but I'd be very inclined. There are two things there. Also, his heart rate has gone up to 130. And there are two things that also are important, that he said that he didn't take any anticoagulants. And so, but he had a certain arrhythmia that I think that is underlying this guy. But I would agree that with one of the previous, that I would probably put the chest drain before I send him for anything. And because this guy is decompensating, and if he's bleeding from his chest, you'd know immediately. And if the pneumothorax is controlled with the chest drain, and so you'd probably put that as before you send him for anything, and you would do your FAST at the same time. Thank you.
Thank you, sir. Atlanta, Doc Frisbee, your comments, please. You're muted, doctor.
Can you hear me now?
Yes, sir. Loud and clear. Go ahead.
I certainly agree with all the comments. I have a question. When you couldn't pass that wire and you were finally successful on the other side, what did your post-insertion look like? Post-insertion chest X-ray look like?
The lung fields, sorry, sir, the lung fields were clear and the new line was in appropriate position.
Okay. Did anybody address that laceration on his scalp?
Yes, before he went to the CAT scanner, we did.
All right. I don't
Good
have
points.
anything further. I think that everything's been covered here. You're going to have to discover this. So first thing would be a chest X-ray and a FAST. Repeat that FAST. That's all I have.
Thank you, Dr. Frisbee. Norfolk, Virginia, Dr. Grigsby, your comments, please.
Yeah, I don't really have anything additional to add. Going back and repeating the FAST, repeating your ABCs, getting the chest X-ray and making sure that there's nothing from your line that caused the issue. But yeah.
Thank you, sir. Ryder, Dr. Varon, your comments, please.
Well, not much to add to what people already mentioned. Obviously, any trauma patient that becomes tachycardic and hypotensive, that's blood loss unless proven otherwise. Other options are attention pneumothorax or pericardial tamponade. This is time sensitive, so probably I would proceed as mentioned before. Physical exam, listen for breath sounds, quick chest x-ray in that case, and repeat the ultrasound both in the chest and the abdomen for a quick diagnosis and finding the source. I'm just curious, when the presentation continues, I'm curious to know what kind of blind was eventually placed. I.e., was this a triple lumen or it was a big MAC introducer? Sometimes old patients, little patients, people end up putting big lines, too big for them, and those dilators can do serious harm. So size does matter of what kind of line was placed on the patient. That could be in relation to the deterioration if there was any vascular injury. Thank you.
Thank you, Dr. Varon. Dr. Hakeem?
Barry, thank you. Yeah, thanks a lot. Just waiting. Yeah, so I do agree with all the previous comments, but since the suspicion of attention pneumothorax or a massive bleed due to that puncture is ruled out, I would look into the cardiac status of this patient because he's elderly. He was hypertensive. He has tremendous pain because of multiple rib fractures. So I would definitely do an 12-lead ECG just to see if maybe the heart is the cause of this sudden drop of decompensated status. And I don't know about the status of the retroperitoneum. The commentator did not talk about that. And besides that, I would definitely look into the subcutaneous tissue also. If you don't have an obvious cause in the torso or any evident bleed, we have seen some patients who bleed in the subcutaneous tissue. There are they accumulate a lot of blood, particularly obese patients who have undergone some type of a gastrectomy. They have lots of potential space. So I would definitely keep that also in my mind. Thank you.
Thank you very much. New York, Dr. Schneidman.
Yeah, and I'll echo what everybody else is saying. I think you need to go back and reassess. I think taking a stethoscope to the chest would be the first step, getting an x-ray, and if you have an ultrasound and you're in the bay, that's the fastest way. You can assess both the chest, the abdomen, and take a look at the cava, see if the patient's perhaps hypovolemic, and fix that as you need to.
Thank you very much, sir. Dr. Tiwari, your comments, please. Dr. Tiwari? Okay, we had Dr. Kiodetis from Panama. Are you still here, ma'am?
Yeah.
Oh, I'm sorry. Dr. Tiwari, go ahead, please.
Yeah. For me, I just agree with that one because after the procedure, his heart rate has increased and his blood pressure decreased. So I also agree with the rest of the team, like, I'll go for repeat chest x-ray and fast scan so that, we can visualize what's going wrong with him.
Thank you very much for your comments, sir. Now back to Dr. Kiodetis. Are you here, ma'am?
Yes, I'm having a very bad connection. Can you hear me?
Yes, ma'am. Loud and clear. Go ahead, please.
So basically, after we did another procedure and something changed in the clinical setting of the patient, I agree that we have to go back and do ABCDs again, do a physical exam to rule out a pneumothorax, attention pneumothorax, and also to see the pupils to see how if they are reactive or not. So basically, do an ultrasound and check what's going on. If something's wrong, something changed, and we need to find out what was that.
So Gary, I think a lot of people make the comment they had some good questions, good suspicions. I think next slide they're going to clarify a lot of things, and then let's see what's going to happen. So I see Dr. Napoleon Mendes here. Maybe he can start to answer the questions next round. So let's continue to Paul.
Okay. All right. So the trauma nurses gave him a bolus and paged us. We immediately returned to the bedside. The patient was lethargic, obtunded, was immediately intubated. We gave him blood, 2 units of packed red blood cells and 2 units of FFP. As everybody had previously mentioned, we repeated his fast, both an EFAST and FAST, which were negative. And after intubation, he got his post-intubation x-ray. which showed this. And now, given our previous comments and thoughts, I'd like to know if anybody's concern had changed or what they think is going on now.
And what do they do next, right?
Yeah. And what would you do next exactly?
Thank you.
Let's go to Texas, Dr. Scooby.
Can you hear me?
Yes, sir.
Well, now, as many of us alluded to, a couple things I see on the chest x-ray. One, the ET tube may be a little deep, that may have to be retracted, but outside of that, it looks like there's some now large whiteout on the right side. So probably start by putting in a chest tube. Since this patient's not doing well, I'll probably put in a 28 or a 32 French, depending on what they have handy. I probably would not move to a percutaneous one now with the patient not doing well. I would first want to decompress that right chest to see what's going on over there.
Thanks, sir. New York, Dr. Schneidman, your comments, please.
Yeah, I think, on the initial CT, it seemed like a extrapleural hematoma. So I wonder if this is a hemothorax or extrapleural. But I think there's nothing wrong with putting a chest tube in and seeing what you get out, and then decide if you need to take the patient to the OR or not.
Thank you, sir. UK, Dr. Villaquirin. Check your mic, sir.
I agree with the previous that I'd probably put the chest drain, but I would take him for a CT scan because I think this, although he's discompensated, I try to see if I can compensate him with the chest drain, but I'm worried that this subclavian, something's happened with the subclavian. I'm still worried about the subclavian, and it's going to be, or if he continues decompensated, then you're going to have to think that he has a subclavian. You're going to have to take him to theater. But if I could compensate him and get a CT scan or get him to a hybrid operating theater, it would be ideal. Thank you.
Thank you. Ryder, Dr. Barron?
I'm just looking. I don't see where the new line is on this x-ray. Anybody can see it? I don't see where it is. Because they put a new line, correct? And I don't see it.
I had to adjust the resolution. It may not just be visible because I had to adjust that to put the image on.
But the new line is on the left side?
There is a new line on the left side.
Okay, and also because of that, you cannot see a lot of parenchyma in there. Just I can't say if there's also a pneuma on the left just because of the x-ray rotation. Okay, and this was an introducer or a triple lumen?
On the right side, it was going to triple lumen.
And what did you put on the left?
Triple lumen.
Okay. So yeah, obviously that is a huge, but that may be extrapleural, that huge opacity that you see there, right where all the rib fractures are. So yeah, I think a chest tube would be reasonable to put in there while you get a chest CT.
Thank you, Dr. Barron. Norfolk, Dr. Grigsby. Check your mic, sir.
Yeah, it looks like you've got a fluid collection there. It looks extrapleural. Put in the chest tube, see if you can get anything out. You said you've intubated him, and you're likely going to have to repair this in the OR.
Thank you, Dr. Grigsby. Dr. Altman, your comments, please.
Yes, I agree with the previous comments. I think the chest tube is important here, and this patient has to go to the OR.
Thanks, sir. Panama, Dr. Kiadetis, your comments, ma'am?
I think I will first put a chest tube and make sure that there's nothing coming out from there. And then it looks like a pleural cap. So it might be a sign of an injury, a subclavian injury. So if the patient is not getting better, he needs to go to the OR.
Thank you very much. Dr. Hakim, do you wish to comment, please?
I agree with the previous comments. Chest tube and probably an OR. Thank you.
Thank you very much. Dr. Alex in Philadelphia, your comments, please.
So I'm more in favor of this being an extra pleural problem. Looking at the costophrenic angle being, quite sharp, but still, I'm in favor of putting a chest tube. There was a rather sudden decompensation of this patient, so I think probably a subclavian artery injury. Venous injury may be a slow bleed, but who knows? Maybe one of the intercostals from all these rib fractures that are bleeding. So I would definitely give this patient MTP to try to bring the blood pressure up, given the fact that he has a head injury. And then I would also want to see what his pulses are on the right upper extremity. Did he lost radial or is significantly diminished compared to the left, to see if kind of supports my theory about the subclavian artery injury. Thank you.
Thank you. Atlanta, Dr. Frisbee?
Well, I don't have anything to add. Of course, the chest x-ray and the chest tube looks like pretty mandatory stuff here. But I think you're right, Philadelphia. I think it's got so many broken ribs that the attempt at putting that
Dr. Frisbee, I think we lost you, sir. Okay, good. Just unmute your mic. We have you back now.
Oh, okay.
Okay, very good.
Yeah, put your chest tube in and have some consideration for all those broken ribs. It wouldn't be beyond the realm of possibility that they're just all of those arteries are just pumping. But that's all I've got.
All right, thank you. Boston, Dr. Hoyman, your comments, please.
I'm scared to say what I'm going to say because I know it's going to sound very stupid. Because I'm going against everyone. I wouldn't put a chest tube on this guy. I think that this guy has, as it was pointed out, an extrapleural hematoma. There is no fluid in the pleural cavity. So I would try to avoid making the situation worse. So this is, if it's an extrapleural hematoma, eventually it's kind of compressed. This guy will need to go to the operating room most likely. But where is the bleeding coming from? It's coming from the subclavian artery or from one of the intercostal vessels. So I would try, if possible, because there is no mediastinal shift. So this is not a tension hemothorax or pneumothorax. So my concern will be if I relieve the tamponade that is occurring in the extrapleural space, I will make the situation worse before knowing what I'm dealing with. And the things I need to know what I'm dealing with is, and my bet will be in the intercostal, I might be wrong, but the reason is if it's a subclavian, I will address this through a median sternotomy with an extension through the supraclavicular space, maybe removing part of the clavicle to assess the subclavian vessels. If it's an intercostal, they are very posterior. This will have to be done through a posterolateral thoracotomy. So the position of the patient will be different. So what I will do with this case, I will not put the chest tube. I will resuscitate the patient very aggressively, try to do a new CT scan, and trying to determine where the source of the bleeding is, because that will determine the way I will position this patient in the operating room. Having said all that, if I don't have any choice, I would think that this is, and probably again, I'm probably wrong here too, because I think that the fact that they tried to put a line that side was presented is for a reason, so probably has an injury to the subclavian vessels. Subclavian vessels, particularly with an injury caused by a line, usually they bleed interpleural. They are extrapleural, but usually the major bleed occurs inside the pleura, which is not the case here. And we saw the extrapleural hematoma related to the rib fractures before. So if I have to take a guess, I would take that guess, but I would try to get this patient to the CT scanner without decompressing, because if I decompress, I might make the situation worse and not have any answers. And please do not kick me out of this conference, because I know that what I say is complete heresy. transferring an unstable patient to the scanner. Thank you.
Dr. Rojman, you are always very, your comments always have a lot of common sense. And you never be kicked out of the room. Otherwise, I would need to be kicked out of the room also. So let's see what happens in this patient.
Yeah.
All right. Let's give Dr. Calderon and Dr. Kasim an opportunity to comment, and then we'll move on. It's okay. Dr. Calderon?
Yes, thank you. I agree with most of the comments. This looks like an hematoma inside the chest. Doesn't look like the usual pleural effusion, and it is must be a rapidly expansive hematoma. I would place the chest tube, but if I can stabilize the patient, if I can improve the hemodynamics, I would take also the patient to the CT scan to do an angio-CT, because we need to figure out where is the bleeding coming from. Might be most likely, I think it might be subclavian artery. But I will take the patient to the CT scan before taking him to the EOR. Okay, thank you. That's
all right. Thank you, Dr. Calderon. Dr. Kasim, thank you for your patience. Your comments, sir.
I'll keep it short. I will join Dr. Hoffman from Boston. I think this is extra pleural. I would not put a chest tube in. I will alert my friendly IR person to help me out. I will go to the CT scanner, get an angiogram, and see if my IR radiologist will be able to repair a lacerated right subclavian artery. That's what I'm thinking. Thank you.
Thank you. Very quickly before we move on, I see Dr. Ginsburg popping in and out. Would you like to comment, sir, or are you observing today? Let's see, where did he just disappear? Okie dokie. Let's go back to Dr. Weinstein, to our presenter.
All right. Excellent. So good comments. Thank you, everyone. As everyone's alluded to, you know, our palms were definitely sweaty at this time, worried about the subclavian artery being injured. He got 2 units of packed red blood cells and 2 units of FFP, as we mentioned, and he responded quite well to that. Neurosurgery was also at the bedside and requesting a stat repeat non-con CT of his head, given his change in mental status. At that time, we didn't really think that was what was going on, but we nonetheless agreed with them it needed to be repeated. We also did not elect to place a chest tube for the similar comments that were made from Boston, worried that placing that tube would uncover a problem that, you know, it's not the right place to place it in the trauma bay, especially given that he had responded to his resuscitation. So we elected, after he responded, to take him to the CAT scanner without a chest tube. The CT of his brain did show he did develop a subdural on the left, which is not in this image, but you can see markedly worsening intraparenchymal hemorrhage on the right side, as well as developing subarachnoid. But here are the images of interest. The first image on the top left shows the most apical portion of the right chest, which essentially has no lung parenchyma left. It's completely covered with hematoma. The 2 other images are highlighting the hematoma, as well as the significant amount of what appears to be arterial extrav into the hematoma. In some cuts, the posterior rib fractures are right here, very posterior, very near the spine, and the arterial extrav was not definitively coming from any one of these particular rib fractures. So we couldn't tell from the CT angio whether or not this was coming from an intercostal or from the subclavian. These images I put up here just to show the location of this rib fracture up here superiorly and how large the hematoma was. So we've kind of hit on this a little bit with some of the previous comments, but would anybody like to change what they'd like to do from here and what to do, where to go and what to do next?
Let's go to Ryder. Dr. Proctor, do you have a comment, sir? You're muted, Dr. Proctor. Yeah, check your mic for me, please. All right. Okay, Dr. Proctor, I'll come back.
I'm sorry, Gary. I'm clicking on the wrong button and then it disappears.
That's all right. Totally all right.
I'm just observing.
Okay. Thank you very much, sir. Dr. Frisbee.
Well, you know, Dr. Hoyman was, looks like he was spot on. You're going to have to decide what approach you're going to take. And the CT scan was very, very elucidative, except for that. We don't know whether we've got a subclavian artery problem or we've got an intercostal problem. So we're at a standstill here until somebody, you know, pulls the trigger and decides to open this patient. I think I might want to try the median sternotomy with an extension, just to rule it out. But that's just me.
All right,
So,
thank you, Dr. Lima, Peru. Dr. Calderon.
It depends on the setting you are. For example, you can take the patient to the hybrid OR that I don't have, call an interventional radiologist to help you out that I don't have, and you can do a thoracotomy or a median sternotomy. I can only help with the chest, but we have to figure it out in OR where the bleeding comes from. We have to stop the bleeding first and eventually drain the hematoma. Well, I have no more comments right now.
Thank you, Dr. Calderon. Ryder, Dr. Barron?
Well, I think this patient had enough radiation therapy for the day, and that's not going to fix him. So I think you're going to have to go to the OR, and if you have to put your money, this bleeding was too fast to be from just the intercostals. I presume that this is going to be then subclavian. It has to be a big vessel. So I would just take him for a thoracotomy, assuming that this is a subclavian artery injury.
Thank you, Dr. Barron. Norfolk, Virginia, Dr. Grigsby, your comments, please.
Yeah, he's unstable and something's got to be done about this. Your best bet's going to be in the OR. Right lateral thoracotomy and repair of what's likely your subclavian there. You might be able to do it all from median sternotomy as well, just depending on where you want to go.
Thank you very much, Dr. Grigsby. Portland, Dr. C.
I just remember, so Gary, just saying, so the patient normalized the blood pressure after the transfusion of 2 units per VCs, 2 FFPs. The blood pressure normalized, okay? He was a responder. He was in CAT scan, at this point, he was stable in CAT scan right now.
Let me make a comment.
Go ahead, Dr. Ginsburg.
Yeah, before I just click on, just a little comment about exposures. The left side is where you can do a second rib, lower, an upper, thoracotomy to get control because the subclavian drops posteriorly and downward, and you don't really need to do a sternotomy on that side unless you need a very, very proximal area of the subclavian. On the right side, you don't really want to get into the chest through the right thoracotomy. You really want to, it takes sort of a superior, goes up into the base of the neck and then drops down below the clavicle. So on that side, it's really more of a either, median sternotomy to get proximal control again, or you can approach it from, in the neck if it's a little bit less proximal, and then obviously the clavicle resection if it's right under the clavicle. So I just wanted to add with regards to the exposure. With this guy, the other thing, I've only had maybe 3 or 4 subclavian artery injuries in the past. And I'll just let all of you know that after, and I'm sure you all have been there, it's not an easy open approach. It's a difficult approach. And if the patient's stable, I think IR is the best approach for these patients. Vascular, either a stent placement or IR stent placement could be the most easy and very fast approach. We have a very good team, and we have sort of a hybrid OR that we convert one of our ORs into hybrid. And by the way, if you look it up in 1998 or around there, I published with our IR group the first placement of a stent across the subclavian artery injury, which we reported at AAST when the first stents were made by Corvida. Corvida was then bought out by Johnson & Johnson. That's it, just a little history.
Thank you for your comments, Dr. Ginsberg.
Just,
go ahead, please.
I was thinking about those intercostal muscles with the broken ribs. I'm not really sure, but I guess you're right. He is stable right now, so going to IR is really much more in the cards for him.
Good. All right. Thank you very much, Dr. Grigsby. Portland, Dr. Kasim.
Well, those of us, like Dr. Calderon says, who do not have a hybrid, normally we have a IR specialist available. An ordinary surgeon, when he encounters like this, I think you need to look at the probability and outcome. The probability is the probability of this patient have had an injury to the vessel during the invasive procedure of subclavian line is really high, because that's when it happened. So I think you are obliged to repair that. I think the quickest way to get into the right side, in my experience, is to resect the clavicle. And I would just go ahead and resect the clavicle, and you'll be looking at it directly, and you can go ahead and repair whatever you need to repair. But of course, like I said earlier on, if you have IR available, that is the best way to deal with this problem at this moment. Thank you.
Thank you. Boston, Dr. Oyman.
Gosh, this is not easy. I couldn't agree more with Dr. Ginsburg's comments. The subclavian artery is a real pain to fix. It's incredibly, surprisingly for being a proximal artery, it's incredibly fragile. It's very easy to make whatever you have there much worse, just trying to pass the vessel loops around the artery. On the right side, there is no question that this should be approached with median sternotomy with extension to the neck, or resecting the clavicle, like Dr. Kasim said. Having said all this, there are a few things here. One is we need to see what neurosurgery needs to do, because if neurosurgery needs to go to the OR to do a decompression, you are forced to go to the OR. The position that the patient will have during their surgery will affect the options that you will have available to you. So that you have to be open-minded that you might need to do not what you would like to do, but only what you can do. The other thing to take into consideration, if we are suspecting an injury and the artery, could be the vein. So in that case, you want to get your fluids from the lower extremities, use the IVC rather than the SVC to resuscitate the patient aggressively. So I would put lines in the groin and try to use those rather than using the lines in the left subclavian. And so what are the options here? I still think that this is probably, I know that this sounds stupid, but I think this is an intercostal. I don't think this the subclavian. But if I don't have any option, which one of the worst options that I have here? Median sternotomy. Can you access the posterior ribs through a median sternotomy? Yes, you can. It's a real pain. It's a real pain. I don't wish that to my enemies, to having to do that, but it's technically possible. So maybe the median sternotomy is the one that offers the best option in terms of a compromise. If I can be sure that this is the intercostals, I will do a posterolateral thoracotomy. And again, all depends. We have IR here. it would take probably like an hour to be ready. I don't know if the guy is stable enough. If it's stable enough, IR, no question, is a better option. First of all, to determine what is bleeding, and many times they can treat the patient without without surgery. However, he also has a bad head bleed. The patient cannot become hypotensive again. So sometimes IR is not the option and surgery is the only one. So besides that, I don't have too much more. Thank you.
Thank you, Dr. Orman. New York, Dr. Schneidman, your comments, please.
Yeah, a couple of things. One, it seems like, you know, this extra pleural hematoma was present on the initial CAT scan, and now it's a lot worse, but it seems to be in a similar location. I don't know. We don't see the whole CAT scan, just a few slices. To me, this doesn't look like a subclavian artery. This looks like an intercostal bleed. So this, and the head scan getting so much worse in such a short period of time, and the abnormal TEG results in admission, it seems like this patient has some kind of underlying coagulopathy, and he came in with a GCS of 14. Maybe he forgot to mention he's on Eliquis or something. So one of the things I would do is make sure we can resuscitate him appropriately with FFP, platelets, maybe even consider giving him PCC, because something is making him very coagulopathic. As far as this bleed, it seems like intercostal to me. I think a posterolateral approach would be the best for that. However, it's very high, so it's definitely going to be challenging. And I think if you have the option of IR and a hybrid suite, I think it would be a great idea.
Thank you, Dr. Schneidman. Panama, Dr. Chiadetis, your comments, ma'am. Dr. Chiadetis?
I think she left, Gary.
Okay, very good. Let's go to the UK. Dr. Villaquirin. Unmute yourself, sir.
I agree with the previous speaker. I think that this is more intercostal than subclavian, but I would probably do an approach. If I didn't have the hybrid, I would try hybrid first. If I don't have a hybrid, then I'd probably use a sternotomy. I want to know the opinion of doing a trapdoor incision. Has anyone done that recently? Because that was one option that I had once, that we had a very difficult subclavian to it, and we ended up doing a trapdoor incision where you have the sternotomy and the thoracotomy, and you resect you dislocate the clavicle, and that gives you the full exposure of subclavians, brachiocephalic, and you expose the whole thing. Thank you.
So Gary, I think you need to move on. And we're going to answer this question afterwards when you see what we did. So I wasn't the case. I was not. For me, this was a intercostal bleeding, and that's why you move. And the patient was stable at that time. So Paul going to say what you did at that point. So Paul.
All right. Next time we'll start with Dr. Alice and Dr. Skubik, who didn't have an opportunity to comment.
Yeah.
So just didn't forget you, gentlemen. Thank you.
All right, and so as Dr. Martos has said, the patient remained stable after getting 2 units and 2 units. Dr. Schneidman said from New York, we actually did end up giving PCC despite his INR of 1.3 because we did suspect that he had a coagulopathy. When he was in our IR suite, they did a thoracic and subclavian angiogram. I'll show the images in the next slide, but the angiogram of the subclavian was normal. They did see a little bit of blush from the subscapularis, from his scapula and clavicle fracture, which they did particle embolize. But they did see a large blush from the 6th intercostal artery on their thoracic angiogram, and they coil embolized both the 6th and 7th intercostal artery. Since we were convinced at that time that the subclavian was okay, we had placed in the IR suite an 8 French pigtail catheter and evacuated all the blood after the angiogram. So the angiogram.
This was an extra pleura. Not intracavital, it was just draining the hematoma, extrapleural hematoma, right? It was not like a chest tube or something going intrapleural.
No, I'm sorry, I should clarify. Yes, the pigtail was placed completely extrapleural and all the hematoma was evacuated. On this angiogram here, it shows a normal subclavian angio here. And then the one on the right side is actually a normal angiogram of one of the intercostals. The abnormal angio requires a run to see, but you can see them injecting the contrast here, and this vessel right here is a normal intercostal. So they coil embolized 2 above this rib space in the IR suite. This particular X-ray was taken a couple days later in the ICU, but I just wanted to show it. He had, the lung did re-expand. The pigtail catheter was in place. We ultimately did end up placing a larger chest tube to completely evacuate the hematoma. The day prior to this X-ray, a small amount of blood had accumulated. But that is how this patient was managed. So I wanted to bring up the topic to kind of close the case out, is what everybody's thoughts are, what they would do if no IR was available and we knew this diagnosis. How would you approach it? How would you stop the bleeding? And to kind of close the case.
Thank you very much. Let's go to University of Texas at Rio to Dr. Skubik. Your comments, sir. Thank you for your patience.
Well, if no IR, and you have an intercostal bleed, then you have to go at it surgically. You could do a thoracotomy over that area and ligate the intercostals, or sometimes you can put big stitches around the rib above it too, and just ligate it that way. Also very astutely, Dr. Schneidman from New York mentioned his coagulopathy, because I think during the case we kind of forgot that they did a TEG when he first came in, and I was just thinking about it, so I wanted to mention it. I think they said he had a prolonged R time, which would indicate that he needs some clotting factors. So I think that was very astute, and maybe that helped slow things down and resuscitate him. But I would surgically ligate it, and then once you're there, you might as well just evacuate the hematoma if you're in the OR already.
Yes, sir. Dr. Weinstein, you're taking final comments at this time. Is that correct?
Yes.
Okay. And so, Dr. Skubik, your final comments, please.
I don't have anything more. Very, very interesting case, and that's always the dreaded injury of getting a subclavian. We had one when I was a fellow that was a gunshot wound to the neck, but the bullet on the X-ray was under the distal left clavicle, and he had no pulse in the radial pulse on the left arm. And so we took him to the OR, and we were actually about to prep him and do a sternotomy. And I actually had his chest prepped and everything. And right as I was to do that, one of the vascular surgeons burst into the door. I'm not sure who called him. And he came in and instead put a stent up, and he had me cut down on the biceps brachial, and he passed it through, and then he pulled the stent back through the brachial and then put a stent across it. Immediately restored blood flow to the arm, and the guy went home in 4 days. I thought it was pretty amazing. That was my experience with subclavian injury.
Thank you, Dr. Skubik. Philadelphia, Dr. Alex, thank you for your patience, sir. Your observations and final comments, please.
No worries. Yeah, interesting case. I agree with all the comments, especially the correction of the coagulopathy, which is key to kind of still have a patient with, a normal brain function after all this is taken care of. With him being hemodynamically stable, I would have asked to go to IR, and I would have asked to do angiogram to see if there's any injury to the subclavian artery. If that's negative, because he also had the CT angiogram. So on the CT angiogram, was there any injury to the subclavian artery or no?
No.
No. So then I would have asked IR, even though they don't see an active blush on the CT scan, or they just see the contrast, to just kind of interrogate and empirically kind of embolize, those intercostals where the fractures were. That's what I would have said. Now, and that seems like it had worked in this case. If IR is not available, and you don't know if this patient has if you're debating between subclavian and intercostals, I think, you would have to start, making sure the subclavian is not injured. So do a supraclavicular incision, maybe even excise the clavicle and look at the right subclavian artery. And if that looks fine, then you will just have to kind of be ready to move on with a posterolateral thoracotomy and control the intercostals that way. Control the intercostals, I think it's sometimes easier to just put clip applier to clip in between the the ribs. If after you open the pleura, it's easy to grab them and maybe clip that and sometimes figure of 8 stitches. But as my colleague from New York said, stitch around the rib, that's also a good option. Great case. Question about the patient's neurostatus. How is he doing? Thank you.
Yes, sir. Dr. Alex, is that for a question for Dr. Weinstein? Could you repeat that? I don't think you got it, Dr. Alex. Your question for him. Did we lose Dr. Alex that fast? Okay, let's go to Boston. Dr. Oyman has to leave in a minute. Your final comment,
I'm so sorry. I need to leave now. I have another school meeting. But I don't think I have anything else to add, except that it was a very, very interesting case. Very interesting. Thank you for presenting. Thank you. I'm sorry I need to leave. Thank you. Bye.
That's okay. Thank you for joining, sir. See you next time. New York, Dr. Schneidman.
Yeah, very interesting case. I think amazing results. You guys should really be proud of saving this guy, and especially avoiding a big operation for him. Without IR, certainly would be very challenging. I think he would get a big incision. You'd have to figure out a way to get suture around his rib to ligate the intercostals, maybe even leave that extra pleural cavity packed for a day or two and come back. But great job, guys.
Thank you, sir. Lima, Peru, Dr. Calderon, your final comments, please.
Yes, nice case. IR was very helpful. And what if I don't have IR? I have to, well, and if I am unsure where does the bleeding come from, I have to choose to do sternotomy with subclavian extension to explore the subclavian vessels, or do a posterolateral exposure, thoracotomy, to stop the bleeding from the intercostal arteries. And I can always change the position of the patient if I don't find the bleeding at the initial approach. Thank you. Nice case.
Thank you, Dr. Calderon. Portland, Dr. Kasim, your final comments, please.
A great case. I was fooled by some of the factors that were mentioned. I was pretty sure this was going to be an subclavian rather than intercostal. So what I would do for the intercostal is yet another approach, which is thoracoscopy. Keep that in mind, and it can easily apply the clip applicator to stop the bleed if IR is not available, which is less invasive than doing thoracotomy. Thank you.
Thank you, Dr. Kasim. Norfolk, Virginia, Dr. Grigsby, your final comments, please.
I agree with a lot of what's been said so far. Very good case. Thank you for sharing.
Thank you, Dr. Grigsby. Atlanta, Doc Frisbee, your comments, sir. Final comments, please.
Well, he did a good job. I don't particularly know much about IR, but if you have it, this is a particularly interesting way to use it. If you don't, like my friend Dr. Calderon, you really just sort of have to dive in and either decide to do a thoracotomy or a posterior approach. If you're sure you've got the if you're sure it's not the subclavian, then you're sort of obligated to the posterior approach. But in this case, you did a really good job with IR. It really saved the old man a real big incision. Nice case. Very well done.
Thank you, Dr. Frisbee. Dr. Hakeem, your final comments, please.
Yeah, thank you, Gary. Actually, a well-managed case, and luckily the patient held on. He responded well, so he could undergo the IR, and that was probably the game changer. Otherwise, if the IR would not have been possible, or it's not available, probably the patient would have definitely 2 big incisions, which would have increased his morbidity. Thank you.
Thank you, sir. Any other final comments before I turn it over to Dr. Martos to close the session? Any final comments before that? Okay, Dr. Martos?
Yeah, so I think the lessons learned here, so if you have placed like a chest tube, may not have this, be able to control this bleeding quickly, because there was kind of tamponading, or even, but it was a big bleeding, right? So that's why I decided not to place the tube, went to IR, the patient stabilized. Luckily he stabilized. If he was not stable, then IR should not be an option, should be a surgical procedure. He had like a bad brain injury, and the prognosis was bad. It was non-surgical by neurosurgery. And again, was a case that was presented to show the management, the difference in management that can have for the same kind of patient, according to the research that you have available also. I would like to say thank you very much for everybody for participating, and I would like to give this ask Paul to make the final remarks. And Paul, thank you very much for your great presentation managing this case.
Well, thank you, sir. I don't have any additional comments. Thank you for allowing me to present.
Thank you very much. So see you. I was going to see everybody again next week with another very interesting case. Thank you all. Take care.